In the last video, we discussed the classification of leukemias. Now we're going to see the clinicals of leukemias. Now the clinical features of leukemia depends upon the rapidity of the onset. The acute leukemias present differently, while the chronic leukemias, they present differently. The acute leukemias, they may present with non-specific features like fever, lethargy, body pains, and ache. There may be prominent features of anemia and thrombocytopenia related symptoms such as shortness of breath, excessive bruising, or bleeding tendency. There may be DIC and mucosal bleeding, which is a feature of acute promyelocytic leukemia, and then on examination you may find pallor, bruising, gum swelling, there may be hepatosplenomegaly, there may be lymphadenopathy. While chronic leukemias, they present differently, they are indolent diseases. For example, many patients are asymptomatic at the time of diagnosis and they're discovered on a CBC to have a problem which is done for some other unrelated reason. There may be hepatosplenomegaly and lymphadenopathy, which may sometimes be presentation. These patients have less bruising and bleeding tendencies. Remember, in patients who got acute leukemias, if they have high fever for 6 hours or more, take it seriously. They can really degenerate rapidly into sepsis and create a medical emergency. So that should be taken as medical emergency. Now the evaluation. Complete blood count is the most important test, and examination of the peripheral smear may be helpful. For example, presence of all rods just give a clue towards acute myeloid leukemia. Then comprehensive metabolic panel, liver function test, coagulation profile, including the D-dimers for the DIC should be done. Flow cytometry, cytogenetics, and FISH testing to distinguish between different subtypes. A bone marrow aspiration biopsy for acute leukemia may be required, but for chronic leukemias, bone marrow biopsy generally is not required because the peripheral blood examination gives us diagnosis. For example, the BCR-ABL fusion protein and peripheral blood FISH analysis tells us about the CML or the chronic myeloid leukemia, while monoclonal B cell population through peripheral blood flow cytometry can tell us about the presence of chronic lymphocytic leukemia. Now the treatment, acute myelocytic leukemia. The general approach is a 7-3 regimen, that is 7-day course of infusion of cytarabine with a 3-day course of an anthracycline antibiotic, either daunorubicin or idarubicin, so they can be used. But generally we adopt a specific approach. This approach is actually based on the molecular markers considering therapeutic and prognostic implications. The scope of this is beyond this presentation. We will discuss in another presentation. Then treatment of acute promyelocytic leukemia, which is slightly different variety of acute myeloid leukemia. Presence of DIC and or rods is a feature of acute promyelocytic leukemia. The promyelocytic leukemias can be classified according to their risk. So risk stratification depends upon the white cell count and platelets. They can be divided into standard risk patient and high risk patient. Standard risk patients are divided further into low risk patients and high risk patients. The low risk patients, they have a WBC count which is less than 10,000, while the platelets are more than 40,000. While intermediate risk patients, they have a WBC count less than 10,000, but their platelet count is also less than 40,000. And high risk patients have a WBC count which is more than 10,000. So this is risk stratification between standard risk patient and high risk patient. The standard risk patients are low risk and intermediate risk patients. So if a patient has standard risk, we can go for all trans-retinoic acid and arsenic trioxide. When we are using this combination, the advantage is there are lesser complications and there is lesser need for rescue stem cell transplantation. While giving this drug, that is arsenic trioxide, QT monitoring should be done because it causes QT prolongation. And patients who got high risk acute promyelocytic leukemia, along with the ATRA and ATU, addition of idarubicin gives better patient outcomes. Then there is a newer drug, CD33 targeted drug conjugate, gemtuzumab ozogamicin, that is GO. During the induction therapy, combination of ATRA with ATO gives better patient outcomes. So this CD3 targeted drugs may be more helpful when combined with this all trans-retinoic acid and arsenic trioxide. Then acute lymphoblastic leukemia. The treatment depends upon it's either Philadelphia positive or Philadelphia negative. If the patient is Philadelphia positive, oral tyrosine kinase inhibitors of second generation are the useful drugs. For example, dasatinib or ponatinib or similar drugs. And patients who are 15 to 40 years, pegylated asparaginase-based regimens preferred if they are tolerated. In patients who are less than 65 years old, hyperfractionated CVAD, which consists of cyclophosphamide, vincristine sulfate, doxorubicin, and dexamethasone, along with high-dose methotrexate and cytarabine can be used. Patients can also be given a bispecific CD19-directed CD3 cell engager, blinatumomab. For patients who are 65 years or older, we can use tyrosine kinase inhibitors as backbone combined with corticosteroids with or without vincristine. Lower doses of hyper-CVAD can also be used in patients who are robust and fit. Chemotherapy-free induction and consolidation regimens using dasatinib with blinatumomab yield good response and improve survival. Now, patients with acute lymphoblastic leukemia who are Philadelphia negative, tyrosine kinase inhibitors are not the drug. They have no role. Patients who are 15 to 40 years, PEG asparaginase based regimens such as CALGB 10403 or similar combinations regimens can be used. Patients who are less than 65-year-old, rituximab based regimens in CD20 positive patients such as GRAAL 2005 or CALGB 8811 and hyper-CVD can be used. Patients who are more than 65-year-old, based on their performance status, we can choose corticosteroid with or without vincristine, POMP regimen, that is prednisolone, vincristine, methotrexate, and 6-mercaptopurine. Lower doses of hyper-CVD can also be used in patients if they've got good performance status. Then chronic myelocytic leukemia. Before starting treatment of chronic myelocytic leukemias, risk scoring should be done. Patient can be put into high risk and low risk category. Different scoring calculators are available, for example, so-called score calculator or UTOS score or UTOS long-term survival score. They assign the patient into high risk and low risk categories. Patients who got high risk, they should be put on second generation tyrosine kinase inhibitors like nilotinib or dasatinib, etc. Patients who got low to intermediate risk, they can be put on imatinib as first line of therapy. Now, when treating the patient with CML, what are our targets? Major milestone after initiation of TKI include at 3 months, BCR-ABL1 should be less than 10% and or the Philadelphia positive metaphase cells should be less than 35%. At 6 months, these should be less than 1% and 0% respectively. And at 1 year, BCR-ABL should be less than 0.1%. So these are our targets when we start the patients on tyrosine kinase inhibitors. And then chronic lymphocytic leukemia. Chronic lymphocytic leukemia is generally very slow, indolent disease. Many patients may not require treatment. Some of the patients who may require treatment, for example, those who got rapid doubling time of lymphocytes, worsening cytopenias, increasing splenic size. If they have got significant B symptoms like fatigue, night sweat, and weight loss, they benefit from treatment. The IGVH mutation status and the deletion 17p and PP53 mutation should be known. These patients, some of these patients may fare well with the treatment and some of them are high-risk patients. So we can use fludarabine, cyclophosphamide, and rituximab or bendamustine with rituximab. For high-risk patients with deletion 17p or PP53 mutation, we can go for venetoclax or Burton's tyrosine kinase inhibitors like ibrutinib, acalabrutinib, either as a single agent or combination with rituximab or obinutuzumab. Older patients with comorbidities tolerate the Burton's tyrosine kinase inhibitors better. Patients with aggressive lymphadenopathy may transform into aggressive diffuse large B-cell lymphoma and rarely Hodgkin's lymphoma or T-cell lymphoma. So these patients require treatment according to their transformation. So this is the outline of patients of leukemia and how we go for the diagnosis and how we plan the treatment of these patients.